that if you are going to train the new generation, so this was the brain behind that, and this is the second session of this practical pediatric endocrinology program for postgraduate. And just our aim is to sensitize and how to approach endocrinal cases we are going to do. So without any delay, just I welcome Dr. Anurag sir to give a note, and then Dr. Ragpati, he should invite Dr. Ragpati sir to brief of that.
Thanks a lot, Dr. Vijay. And this, I think, is a wonderful program which has been going on for so many years. I remember many years ago we had a program in Bangalore in a physical form, then in Coimbatore and Hyderabad. And since the online version has come, this program has taken real high stakes, and it's been one of the, I would say, flagship programs of ISPAE that we have been there. All kudos to Raghupati sir and Amarnath, who has been tirelessly working in this regards. So we know that pediatric endocrinology is an important part of pediatrics, and it's been often felt that this is one area which has often been neglected in postgraduate training, resulting in difficulties subsequently. And one of the best way to improve the quality of care of pediatric endocrinology, of course, would be to improve the level of knowledge of pediatric endocrinology amongst the pediatricians and particularly the trainees. So this program is something which is very unique and provides the right opportunity to interact in that regards. And we have today a wonderful galaxy of speakers, Dr. Vaman Khadilkar, Professor Anju Seth, who along with the whole team will work towards enhancing our knowledge about growth disorders. It's indeed a pleasure and honor to start off this program and to hand over the proceedings to Dr. Raghupati sir. Sir, please carry from.
Good evening, everybody. And it is really a pleasure to see that the program started initially as offline is going on and going on quite regularly also. As was already told, the idea is to lay the seeds of pediatric endocrinology even during the postgraduate period, and so that they could specialize in this area, and also to fulfill the gap that I have had as a postgraduate trainee. Nobody taught me endocrinology, and there was nobody to teach. And unfortunately, that's the situation in many medical colleges even today. There's nobody to teach pediatric endocrinology. But regularly questions are asked for the theory exam, both for MD and DNB postgraduates, and they find it very difficult to answer in a professional way. And the idea of starting this program is to fulfill that deficit. And I'm happy it's going on. And thanks, Dr. Vaman, and thanks, Dr. Anju, for joining this program. And Vaman and Anurag have been regular, even when it was held in person, in offline, in various places that he mentioned already. And without further ado, I think we'll move on to the first presentation. Over to Dr. Vijay.
Thank you, sir. Case 1 is on growth assessment, that is endocrine short stature, and Dr. Sahana is going to present the case. Dr. Amarnath will be acting as a guide, and followed by Sir Dr. Vaman Khadilkar sir will be examiner for the case, and followed by lecture on growth assessment and monitoring. So I invite Dr. Sahana to present her case. She is clinical fellow in pediatric and adolescent endocrinology at IGICH Bangalore. Over to Dr. Sahana.
Good evening to everyone. Good evening to everyone. Sir, is everybody able to see the slides, sir? Is it in the slides?
Yes.
Yes, sir. Thank you, sir. So hereby I'll be presenting a case of 10-year, 6-month-old girl child hailing from Bangalore, presented to us with the mother, mother is the informant here, who is a reliable informant. The child came to us with the history of history of not gaining adequate height, which was noticed by the mother since 1 year of age. So coming to history of presenting illness, 10 year 6-month-old child was brought to us with history of not attaining age appropriate height as compared to her elder sibling, which was noticed by the mother from 1 year of age. From 1 year of age. So child had prior to 10 year 6-month-old, a child had presented to us at 1 year 5 months of age with history of not gaining adequate height noticed by the mother, and child was initially had undergone basic evaluation at IGICH and was advised on advanced investigations, which was not done. So later on they came to us directly at 3 year 5-month-old again with the same complaints, and finally they came to us at 10 year 6-month-old of age. So child has been throughout over the course of years, child has been sitting in the first bench at school from first to fifth standard, and there are no any recordings of personal or school recordings of height and weight which were available with the parents. And currently, child is being studying in the fifth standard with good scholastic performance. Coming to the negative history wise child, they did not give any history of any dry skin, constipation, lethargy, decreased appetite in the child, poor scholastic performance, no history of any polyuria, polydipsia, headache, vomiting, and visual disturbances, no history of any seizure disorder or altered sensorium in the child previously, no history of easy fatigability, giddiness, weight loss, or vomiting in the child, no history of trauma, surgery, or radiation exposure, no history suggestive of any other chronic illnesses pertaining to systemic disorders. On probing, mother did not give any history of pubertal signs which have developed in the child. Coming to the past history, they gave history of decreased activity, poor feeding, and constipation at 2 months of age of the child, for which the child was evaluated elsewhere and found to have low thyroid hormone levels, and the child was started on tablet thyroxine. So over the course of years, child had been compliant and taking adequate dose as confirmed with the thyroid function test, which was done by the pediatrician to the thyroid medications. So apart from this, child has never been admitted for any other illnesses. Antenatal history wise, antenatal history is uneventful. Birth history, it was a term gestation, born through LSES because of previous LSES with a birth weight of 2.8 kgs, and child had cried at birth. There is no history suggestive of any difficult labor. Birth weight was 2.8, but birth length was not available. But according to the parents, child was not short at birth. There was no history of any edema at the time of birth. Postnatally, child did not have any history of seizures or low blood glucose levels or prolonged jaundice. Family history, it's a second born child to a second degree consanguineously married couple with and there was no history of any short stature in the other family members. Developmentally, development is appropriate for the age, and child is being studying in 5th standard with good scholastic performance, and child is immunized up to date according to national immunization schedule. Coming to the summary, it's a 10 year 6-month-old girl child, second born to a second degree consanguineously married couple with normal birth and developmental history, diagnosed with hypothyroidism at 2 months of age and has been on levothyroxine since then with good compliance. So now presented with history of not gaining adequate height, noticed from 1 year of age with no history suggestive of any chronic illnesses. So by the end of summary, what are the doubts that we have here is what could be the possible etiology of hypothyroidism in this child, whether it is primary or secondary cause, and child is being on adequate doses of growth thyroid hormone, and even then child's height gain is not adequate according to the mother. Could there be an additional hormone deficiency in this child? Or if it is a primary hypothyroidism, would it have caused growth hormone resistance if not treated appropriately? Or being a girl child, this could also be a case of Turner syndrome, or this could also be a case of genetic syndromic short stature. Shall I proceed with the examination, sir?
Yes, please. Yeah.
Yes. Coming to the examination, at the time of examination, child's vitals were stable. Anthropometry at 10 years, 6 months of age, height being 73 centimeter, which accounts to less than -8 standard deviation. Weight being 7.4 kgs, which accounts to less than -8 standard deviation, and BMI being between 5th and 10th centile, which is at -1 standard deviation. As we can see, with MPH of 155 centimeters, as we can see, child is very much below, less than -1, less than -8 standard deviation, which is being very far away from its genetic potential. And at chronological age of 10 years, 6 months, height age, weight age, both being less than 1 year in the child. And upper segment lower segment ratio being 1 in this child. So by the end of by the end of growth chart assessment, the height being less than 3rd centile and actually less than 1st centile, less than -8 standard deviation, very much far below from its mid-parental height, and height age, weight age being very much less than chronological age, and child is having proportionate pathological short stature.
Can I have a suggestion? I know that I'm interrupting.
Yes.
But it's always a good idea to also have the target height Z score.
Yes. Yes.
Ready for, because your child here is very short,
Yes.
but sometimes when the difference is not that stark, the difference between the child's height Z score and MPH Z score becomes critical.
Okay.
Okay, please proceed.
Head-to-toe examination, as we can see in the picture, child has frontal bossing with mid-facial hypoplasia, with very cherubic angel-like faces, with infantile voice on examination, with protuberant abdomen. Head-to-toe examination-wise, there were no other significant features. SMR being prepubertal with anastaging of 1, and child systemic examination being normal. Coming to the summary at the end of examination, it's a 10-year, 6-month-old girl child, second born to a second-degree consanguineously married couple with normal birth and developmental history, diagnosed with hypothyroidism at 2 months of age and has been on levothyroxine since then. Now presented with history of not gaining adequate height from 1 year of age. On examination, height and weight being less than -8 standard deviation with features of mid-facial hypoplasia, infantile appearance and voice, and abnormal distribution of body fat with normal systemic examination. So coming to the DD at the end of my history and examination, this could be a case of multiple pituitary hormone deficiency, where the child has hypothyroidism as well as features of growth faltering, which could be secondary to growth hormone deficiency, or this could be a case of growth hormone insensitivity or resistance, or this could be a case of this could be secondary to genetic syndromes, or Turner syndrome and congenital hypothyroidism being very unlikely in this child. So my first DD would be multiple pituitary hormone deficiency, that is secondary hypothyroidism with growth hormone deficiency in the child. So what are the points which are favoring for growth hormone deficiency or insensitivity in this child would be a normal birth weight in this child, and the onset of short stature which was witnessed by the mother after 1 year of age, and developmentally child being appropriate, and there is a proportionate pathological short stature in the child, and the head-to-toe examination favor mostly towards growth hormone deficiency, as child has mid-facial hypoplasia and pot belly, and no other systemic involvement which is seen in this child, such as cardiac or renal involvement or any other systemic involvement in this child. And what are the points against? Child did not have other typical features of growth hormone deficiency, such as child didn't ever present with hypoglycemia, seizures, or prolonged jaundice, and weight age, height age both being very much reduced, that is less than 1 year in this child. So shall I continue, sir?
Yes, please do. Yeah.
Yes, sir. So as child had presented to us at 1 year, 5 months and 3 year, 8 months of the child, we have the hospital records of the child's anthropometry. When the child came to us at 1 year, 5 months of age, child's height was 53 centimeters and weight being 5 kgs. At 3 years, 8 months of age, child's height was 61.5 centimeters. At 10 years, 6 months of age, child's height was 73 centimeters. which gives us the growth velocity of 1.6 centimeters per year. As we can see here, the child's growth velocity being very much below than, very much less than 25th centile. And as we did bone age for the child using Tanner Whitehouse 3, child's bone age at 10 years, 6 months of age was 4 years, and the bone age is delayed by 6 years. So in this child, who is a chronologically 10 year 6-month old child with a bone age of 4 years and height age, weight age being less than 1 year. Shall I proceed with the investigation, sir?
Just a couple of questions or comments.
Yes.
Generally, a kid with growth hormone deficiency starts manifesting at the end of about 1.5 years. But the growth deficit is usually not this profound at 1.5 years of age. And also, a second point of note, or rather question for you, is that do you know of a condition in which a child is born small who may have an GH-IGF-1 axis defect?
In IGF-1 deficiency, child can be born.
IGF-1 deficiency or something else? You're close to the answer. Because generally, growth hormone deficient children are not born
Not
SGAs.
born. Yes, sir.
They are of normal weight usually. So IGF-1, but which IGF-1 defect? Is the IGF-1 receptor defect.
Yes.
Right. Carry on, please.
So coming to investigation, Tier 1 investigations as a complete blood count with peripheral smear, renal function test, liver function test, VBG, calcium phosphorus, and serum electrolytes being normal. And upon doing endocrine investigations, child's TSH was 0.01 microinternational unit per ml, which was very low. For the FT4 value of 0.9 nanogram per deciliter and total T4 of 9.4 microgram per deciliter. So this shows that FT4 being normal for a very suppressed TSH is suggestive of secondary hypothyroidism in the child, and other hormones such as serum 8-AM cortisol, serum osmolarity, and even osmolarity being normal.
May I ask a question with the permission of Dr. Amarnath and Dr. Vaman?
Yes, sir. Yes, sir. Please.
Is this child on treatment with thyroxine at this time when the investigations were done?
Yes, sir. Yes, sir.
He was on treatment.
Yes, sir. She was on treatment from 2 months of age, sir.
You also said that the child was on thyroxine for a long time. Do you have previous thyroid reports?
So prior to 1 year, 5 months of age, sir?
No. You said some pediatrician was monitoring. Do
Yes.
you have all those details?
No, sir. So whenever the child came to us, those values we have, sir.
The parents are not keeping any record.
Orally, they had told that the values are being maintained. That's all, sir.
Oh, okay.
Yes.
Now, while we are at it, Dr. Sahana,
Yes, sir.
looking at this endocrine profile, would you still consider the diagnosis of growth hormone insensitivity?
So with this evaluation, sir, so this could be a case of multiple pituitary hormone deficiency.
That I agree. But
Yes,
would you
sir.
still consider the diagnosis of growth hormone insensitivity syndrome, LARN?
Larynx, with this evaluation, doubtful.
What am I asking you is, do you get central hypothyroidism in growth hormone insensitivity syndrome?
I'm not sure.
You don't usually. Yeah. Okay, carry on, please. Yeah.
So we went ahead and did Florida stimulation test in this child after priming, as she was 10 years, 6 months old. And upon doing this, at 0 minutes, the value was less than 0.05 nanogram per ml. And at 30 minutes, 60 minutes, 90 minutes, and 120 minutes, the values being less than 0.05 nanogram per ml. So this suggests the child has growth hormone deficiency. So So we had already demonstrated child had secondary hypothyroidism with growth hormone deficiency, and upon doing MRI brain, child had hypoplastic anteropituitary gland with postopituitary bright spot being present. And we went into genetics for this child, and whole exome sequencing showed the POWN F1 gene mutation, which was homozygous and autosomal recessive, but it was a variant of unknown significance. So this shows us that the child has multiple pituitary hormone deficiency secondary to a POWN F1 gene mutation. So according to the features which are present in POWN F1 gene mutation, our child had secondary hypothyroidism, which presented at a very early age, which is typically seen in a child with this gene mutation, along with growth hormone deficiency. And such kids will also have prolactin hormone deficiency. So coming to the management, as the child was already on levothyroxine, the dose was optimized according to the further thyroid profile tests, and parents being counseled regarding the need for growth hormone therapy, and the informed consent was taken, and the child was started on recombinant growth hormone therapy at 10 years, 6 months of age with 30 mics per kg per day. So coming to the monitoring, so this is the growth chart, which is depicting increase in height as we after we started the growth hormone at 10 years, 6 months of age, along with increase in the bone age of the child, which we have been monitoring sequentially. And currently, child has gained 99.6 centimeters with a bone age of 8.7 years. And currently, the height velocity of the child is 12.1 centimeter per year. So this is the height velocity chart, which is showing increase in the height velocity from before and after starting the therapy. So the plan for this child is to monitor the anthropometry every 3 monthly and monitoring IGF-1 levels, which is supposed to be between -2 to +2 standard deviation, and to assess the pubertal status during each visit, and bone age to be done every year, and to monitor for side effects of recombinant growth hormone. And plan is to do serum prolactin level on follow-up. Thank you, sir.
Just a question, Dr. Sahana.
Yes, sir.
When you started growth hormone therapy, did the level of free T4 drop?
Free T4. No, sir. No, sir. It is supposed to form. Usually, it causes resurfacing of hypothyroidism in a child, but it did not, sir.
Generally, your thyroxine requirement goes up and your T4
Increase.
drops.
Yes. Yes.
But here it did not happen. That's a good thing, but a bit surprising actually. Okay. Fine. So I'm a bit surprised that it was reported as a variant of uncertain significance, because
Yes.
POW1 F1 is a very well-known transcription factor. The thing is that the specific amino acid sequence change which has been shown has not yet probably been reported in that database. So if you actually report this case in the database, then if next time a person finds it, it would then be called as pathogenic. I think it's very important for all of us to remember that we need to report these cases as clinical cases, and therefore this is a significant deletion. I think as we learn more and more about genetics, all these variants of uncertain significance will eventually become of significance. So please report them whenever you could to the database, and of course publish that article.
Yes.
So it helps to build the database.
May
Okay,
I
so
ask a question, Vaman, with
yes,
your
yes.
permission? So I just wanted to ask you, Sahana,
Yes.
why did you start the child on a relatively high dose of growth hormone? 30 mites is for somebody who is so growth hormone deficient. Don't you think you gave a very high dose?
Yes. This was started in yes. Initial dose should be 20 microgram per kg per day. In a growth hormone deficiency child, it's a bit on the higher side.
Thank you.
Thank you, ma'am.
So Amarnath, do you want to ask any questions or any comments?
Nothing, sir. This case was reconstructed. Dr. Vani is on leave, so I have seen this. Actually, we don't know exactly the sequence. So thank you very much, Sahana and the
Thank you, sir.
sir. And we are likely to hear both of your lectures. Thank you.
Thank you.
So Dr. Sahana, please stop your presentation.
So Vijay, shall I start with mine or?
Yes, sir. Yes, sir. Please, sir. Dr. Sahana, just you have to. Yes. Thank you, sir. Yes.
I'll share my presentation.
Yes.
Vijay, please check if you can see my slides.
Yes. It is visible and audible, sir. Yes.
All right. So first of all, would like to thank organizers of PEP, Professor Vijay Jaiswal, Amarnath, and thank you, Professor Raghupati, for starting this long back as physical and now virtual. Thank you, Anurag, for that introduction. So moving on, I'm going to speak on growth assessment and monitoring. So first question is, why should we actually monitor growth in children? What is the need to monitor growth? Now, as you all know, children's growth monitoring is an essential part of child health surveillance. And whenever we go to any developed part of the world, the first thing that is handed over to any newborn is something like a red book in UK or a growth booklet in America. And there you're supposed to monitor growth of the major anthropometric parameters, because growth monitoring alone has shown to improve children's health and reduce mortality and morbidity without any intervention across the world. So remember, it's a bit like monitoring your blood sugar in diabetes. The more you monitor, even if you don't change the insulin dosages, your HbA1c improves. That has been shown in several studies. Therefore, just monitoring itself keeps an eye on the child's growth and make you pick up the disease at a much earlier time rather than at a later date. What are the normal parameters and how often should we monitor them? And what are the Indian guidelines for that? So in 2007, the Indian Academy of Pediatrics wrote growth monitoring guidelines. And these state that how often to monitor. Under the age of 3 years, we take the chance of vaccination visits and monitor at birth, 6 months, 6, 10, and 14 weeks, then 9 months, 12 to 15 months at each immunization. And then additional timings are 6 monthly. And always whenever a child comes for visit for some other reasons, such as minor illness, etc., that opportunity is to be taken to monitor parameters. And which parameters do we look at? We look at the weight, the length or height, and the head circumference. And for older children, 6 monthly is recommended, height, weight, BMI. I will also add blood pressure to it. Now, which growth charts do we use? Now, the 2015 guidelines clearly state that for children who are under the age of 5 years, we use WHO growth charts, which have been simplified by IAP. So either they could be used or WHO's original growth charts can be downloaded and used. For 5 to 18-year-old children, we use the IAP growth charts. Now let us go to very basics of growth charts. Now these are the IAP simplified WHO growth charts. And all 3 parameters are combined on one page. So the front page shows you length at the top, head circumference in the middle, and weight at the bottom. And the reverse of it, the flip side, shows weight for length. Now, many of the postgraduates would be aware that initially in days gone by, when WHO started monitoring of growth, most people did not know their child's date of birth or their age. So WHO came up with age-independent criterion, and there were mainly two. There were three, but mainly two that we still use. One is weight for length, and second is the upper mid-arm circumference. These are age-independent criteria because many children did not know, didn't have age, or their parents didn't know the date of birth. Now, if you focus on the charts, it shows 4 lines. The line in the center is the average or the 0 z-score or the 50th percentile line. Then the line at the top is 97th percentile or +2 z-score. That's the upper limit of normal. And the line at the bottom, the 3rd percentile or -2 z-score, is the lower limit of normal. And there's one more red line at the bottom, which is -3 z-score, which is very abnormal. Or in other words, you are looking at the extremes of normal, and then there is that -3 z-score, which is very, very subnormal. For the head circumference, however, you have only 3 lines. You do not have the -1 line because head circumference needs to be picked up early if it is not following a normal curve. But for weight, you still have the 1st percentile line as well. Weight for length, remember, the line in the middle is 0 z-score or 50th percentile. The orange line is -2 z-score, or what is considered as the cutoff for MAM, and -3 z-score is considered as the cutoff for SAM. That is 0.1st or 1st percentile. The top line, however, is +3, that is 99th percentile. And that is the limit above which younger children are considered to be obese. So remember that WHO says that for older children, +1 is overweight, +2 is obese, but for younger children, +3 is obese. So a lot of breastfed children in the world are quite plump and they lose that fat. So WHO actually makes an allowance for younger children, and therefore the cutoff for obesity is higher. It's important to remember that it's +3 z-score. Then coming to our 5 to 18 IIP growth charts, again, very similar concept. You have the weight chart and the height chart on this sheet. Again, the same thing. 50th percentile is 0 z-score, 97th is +2, and -2 z-score is 3rd percentile. And then you also have the 10, 25th, 75th, and 90th percentiles. Similarly, for weight, you have same distribution. But I would like to draw your attention to one important fact about weight, is that unlike height, where the percentiles are equally distributed, the weight percentiles are skewed. So as you go up on the percentiles, the gap between each percentile significantly widens. So these are not normally distributed numbers. They are always skewed to the right with a long tail on the right side. So you get a chart which is skewed. Then coming to the BMI charts, as Asian Indians have much more central body fat. Therefore, to define overweight and obesity, WHO has recommended that we lower our BMI cutoffs, and therefore the pediatrics cutoffs have been appropriately adjusted to match with 23 adult equivalent as overweight and 27 adult equivalent as obesity. And the IIP growth chart depicts the same. The orange line is overweight, 23 adult equivalent, and the red line is 27 adult equivalent of pediatric obesity. And to decide whether the child is underweight, the cutoff is 3rd percentile on BMI. Some growth charts in the world show 5th percentile as the cutoff for underweight. Now that depends on which standard was used and which population was referred to in constructing the growth charts. Now, because the obesity is rising so much, in 2023, when IIP wrote the obesity guidelines, IIP BMI charts were extended. So what you now have is class 1, class 2, and class 3 obesity. So IIP Obesity Guideline Committee has designed extension of the existing IIP BMI charts as class 2 obesity is more than 120th percentile but less than 140 percentile of the IIP obesity cutoff. and class 3 is more than 140 percentile of the IIP obesity cutoff. So these are the newly designed IIP extended charts, BMI charts. So the magenta colored line is the class 3 obesity, above 140% of the obesity cutoff. Class 2 obesity is above 140%, but between 140 and 120 and 140%. And the red line is the 27 adult equivalent that we just saw. And orange line is 23. So you now have class 2 and class 3 obesity defined for Indian children using extended IIP cutoff. This graph is for girls and very similar for boys. Now let us take an example of plotting the growth chart. Here is a 3-year-old child, boy, whose length is 95, weight is 15, and head circumference is 48. So this is how you plot it. Now for the purpose of demonstration, here I have made big blobs, but in real life, you just put a small point and continue to plot them as points, and you can join them to form a line. So in the given example, the length is nearly on the 50th percentile, so is the weight, and so is the head circumference. So this is a child who is growing according to the median of the WHO charts. The same when you plot on weight for height, you realize that the weight is actually above the 50th percentile, but still way below the 99th percentile. So very normal child in all respects. This is what you need to do. One reminder for the PGs, whenever you are plotting on young children's growth charts, and if you have a baby who is preterm, you must always correct for the gestational age up to 2 years of age. Beyond 2 years, you don't need the correction. To give you an example, if a child is born 2 months earlier, if a child is born at 34 weeks, at 32 weeks, and that child comes to you at 1 year of age, you are going to plot it at 10 months, not at 12 months, because the child was born prematurely. Now, you continue this correction until the child is 2 years old, and beyond that, there is no need for correction. Then the concept of mid-parental height. See, we always say that children grow according to their genetic potential. Now, the best proxy that we have for any child's genetic potential is to take parent's height. But there is an adjustment factor. So the adjustment factor is that of 13. Here you see the formula that for boys it is adding 13 and for girls it is subtracting 13 from both parents' heights and then dividing it by 2. This is then plotted at 18 years of age on the chart to see which percentile it matches. Target height is between 6 to 9 centimeters on both sides, depending on which textbook or which reference you follow. It depends on which standard deviation you have taken, +1 or +1.5 or +2. So here is an example of how to chart the target height. If the target height is 164 centimeters, then the target range on IIP chart is given as ±6 centimeters. So you draw a double-edged arrow starting at 158 and ending at 70. And right at the middle, 164 is your target height. This is how you mark it. So for this particular family, boys should fall within the range of 3rd percentile to about 25th percentile. This is how you interpret mid-parental height. Now, there are certain other adjustments that have been suggested in families who are too short and too tall, extremely tall people or extremely short people. There you take something called conditional target height. So the formula then is you have to calculate the mid-parental height z-score and multiply that z-score by 0.72. This corrects for the extremes in too short and too families. And if you then take z-score for the parent for the previous generation charts, you also correct for the secular trend. Now here I have shown one more example of a child who is growing on the 3rd percentile or just below 3rd percentile. But when you correct it for mid-parental height as shown in this cartoon on the growth chart, where father is short, mother is short, and the target height works out to be 160 centimeters. And the bottom of the arrow shows that for this family, the low percentile actually is below IIP 3rd percentile chart. But when you draw that percentile parallel to the IIP's third percentile, you realize that this child is normal, does not require investigation. All that this child will require is regular monitoring of growth to make sure that he continues to progress on the third percentile with a normal growth velocity. Now, I spoke about the BMI, but how do you calculate BMI? You calculate BMI as weight in kgs upon height in meters square. Now, from what age can you use BMI? Beyond 5 years of age. In younger children, as I said, weight for length. There are many advocates nowadays who actually say that if you have an accurate age of the child, BMI is a better assessment than weight for height at all ages. At all ages, there are multiple papers now to suggest that BMI is more sensitive than weight for height, which is an age-independent criteria. So if you know the weight of the age of the child, you can also use BMI right from very early age. I have already gone through this, so I will skip these 2 slides. Now there are the new IIP growth chart, the pediatrician friendly growth charts has 2 new additions. So one in the left-hand corner on your screen is the BMI lookup tool. A lot of busy pediatricians do not have time to calculate BMI. So this tool works as weight for height. And this tool calculates the mid-parental height. And I'll show you how to do that. So here is the tool which I have blown up to show you. So if you have got a child who is 135 centimeters and whose weight is 30 kilos, then it's normal. Same height, weight 35 will be overweight. Same height, weight 45 will be obese. And same height, weight 20 will be underweight. So for the pediatrician, this is very easy to follow. Having said that, they must again check it. The referring doctor or the institute where it has been referred, there we must calculate the BMI and confirm what the tool has shown is correct or not. This is just a screening tool, but a very useful tool in the OPD to follow. Similarly, rather than doing mid-parental height complex calculations, this is the tool that has been provided. Here, all that you need to do is join the mother's height to the father's height by drawing a straight line or an oblique line and read off the percentile in the center. In the shown example, when you join the mother's height to the father's height, the mid-parental height centile comes very close to the 50th. So here you easily know that the child should be falling around 50th percentile. Now, what do you do when you have to plot preterm babies? So for all preterm babies, you use intergrowth 21 charts, which are specifically designed for preterm gestational age, and they amalgamate very smoothly with the WHO growth chart at term. So there is Indian data from Nagpur in the making of the chart. So we should use intergrowth 21 for plotting preterm growth. This is an example of an SGA for a girl. And last was an example of AGA and SGA for boys. So please use intergrowth 21 chart for preterm infants. Now, these are the recommended cutoffs, which I have already spoken of. So I won't go into the details of the table. This is published in the IIP guideline, and you can read it in the article if you so wish. Now, are there any other important parameters of growth that we use for monitoring in children? We use height velocity, and the way to calculate that, as it was already nicely shown in the case by Dr. Sahana, is you calculate growth velocity by delta height upon delta time, change in height upon change in time, and you plot it at the midpoint of the 2 height intervals. And anybody who is below the 25th percentile, now please note, not third percentile, 25th percentile for velocity chart is considered to have growth failure. But at the same time, please remember that the minimum time period required for monitoring growth is 6 months and ideally 1 year, because children's growth is seasonal. You have already seen a demonstration of this in the case that was presented. And here we have shown the same thing, that the growth velocity in this example was 4 centimeters at 10 years in a girl, which falls below the 25th percentile, which is abnormal. These are the same height velocity charts which we have already seen, so I'll skip that. Now, if somebody is not carrying the height velocity chart, this is a simple way to remember. In the first year, a child grows about 24. It halves by second year to 12, halves by third year to 6. And from fourth year till puberty, it is 5 centimeter per year. In boys, there is prepubertal slowing, and they can go to as low as 3.5 to 4 centimeter per year, which can be normal. And during the spurt of puberty, they will grow between 8 to 12 centimeter. Boys a little higher than the girls. Now, any other parameters that we monitor for OB children? Yes, as per the definition of metabolic syndrome by IDF, we need to monitor waist circumference. So this was the article that we wrote on Indian children's waist circumference chart in 2014, which has now been adopted by IAP as IAP waist circumference charts from 2023. And here you can see that these are waist circumference charts, and the 70th percentile is considered to be danger line. So if a child's waist circumference is above 70th percentile, then can be at risk of metabolic syndrome and needs to be checked. Now, are there any proportion charts available? For example, if you have a child with skeletal dysplasia like this, then you do have proportion charts, which are Indian proportion charts. Upper body, lower segment ratios are available, as well as sitting height percentile are available for Indian children. What's important to remember is that the discrepancy between the upper segment and lower segment should be more than 2 standard deviation to call somebody disproportionate. So it's a wide gap, more than 2 standard deviation between upper segment and lower segment. Now, for endocrinologists, we also have extended IAP growth charts where minus 2.5, minus 2.25, and minus 3 Z-score lines are depicted. So we can monitor children in specific conditions such as idiopathic short stature, severe short stature, and SGA, where these cutoff lines are useful, and you don't need to move around with a calculator and an LMS data to calculate the Z-score. This is easy lookup. Now, one important concept when it comes to making a diagnosis using growth charts is how far below the third percentile. Now, Dr. Sahana showed this case where the dot was way below the third percentile. So remember, when the height deficit is just below the third percentile, you are looking at idiopathic or familial short stature, constitutional delay, chronic malnutrition, or SGA baby. Whereas if it is as low as this, you are looking at a major diagnosis. Skeletal dysplasia, endocrine disorders, syndromes, bone disorder, very severe chronic disease like chronic renal failure. So this how far below the third percentile is a very good point to remember when it comes to assessment of short children. There are disease-specific growth charts. We should use disease-specific growth charts for children with Down syndrome, Turner syndrome, etc. whenever available. We now have Indian Turner syndrome charts available and are extremely useful to monitor girls with Turner syndrome. Then, how do you identify short stature and points in growth monitoring? Check the accuracy of the measurement that you do. Always calibrate your equipment. Look at the trend of deviation. Crossing percentile upward or lower is very important. And then get into a habit of calculating height, age, and weightage. Just like you calculate Z-score, when you do not have Z-scores available, a quick height age or weightage and bone age can be very useful, as shown here. So this child's both parameters appear on the third percentile, but when you do a height age and weightage by drawing a parallel line and then a perpendicular, you realize here that the weight deficit is more than the height deficit, as shown here. Therefore, this child has chronic systemic disease. Exactly contrasting to that, here is another child whose both parameters are less, weight on third percentile and height below third percentile, but the height age is much lower than the weight age. So this is likely to be an endocrine cause of short stature or a syndrome. Exactly opposite when you have a child who's tall and heavy. If you calculate the height age, weight age, here you realize that the height age is much more than the weight age. So this is precocious puberty, Now in this little box, I have put up all the common combinations and permutations that you see for height age, weight age, and bone age. That helps us to decide the direction in which our investigation should go. I won't read this algorithm. This has been put in the guidelines. So this is how you proceed when you are looking at growth monitoring and assessment of a short child. There are many software tools available now. You have the IAP growth chart application, and I was pleased to note that you had used it in your case. It now also gives you Z score. This is application designed by All India Institute of Medical Sciences. It gives you WHO and IAP Z score simultaneously. There are some tools for PG students who want to do anthropometric assessment and get Z scores on various Indian parameters. So if you write to me or mail to me, I can provide you with these templates where you can get Z score directly on thousands of children at one go. Just makes your thesis easier. So to conclude what I said, growth monitoring and anthropometry are invaluable tools in the hands of a pediatrician and healthcare worker. Please get into a habit of plotting growth until the age of 18 years. Don't stop at 5. Growth charts help to reduce expensive investigation. Use WHO charts for younger children and IFP charts for 5 to 18-year-old. And many other Indian anthropometric parameters and software tools are not available at your disposal. So thank you. And once again, thank you for the opportunity, and hand over to Dr. Vijay Jaiswal. I'll stop sharing my screen.
So thank you, sir, for the lucid lecture. So we can have 1-2 quick questions if somebody has.
Yeah, sure.
Sir, on behalf of PG students, I am requesting you how to monitor the other hormones when you start growth hormone, or when you want to start growth hormone in multiple pituitary hormone deficiency, how to start?
Right. I think first thing to understand is, although all these divisions which are based on genetic testing, such as POW1F1, PIT1, LHX3, LHX4, etc., are good guidelines, but they are not absolute. Whenever you have encountered a patient who has multiple pituitary hormone deficiency, or you suspect multiple pituitary hormone deficiency, be vigilant. Any hormonal deficit can creep in over a period of time. But to start, number one, we must always make sure that we have checked cortisol before we give thyroxine. So unless the cortisol values are normal, please do not start a patient with thyroxine. You can precipitate Addisonian crisis. So when we give growth hormone, before that we normally check all the values, and only when a child is euthyroid, you would do a growth hormone stimulation test. Having done that, and when you start it, monitor pre-T4, but also keep on monitoring other hormones, because as time goes by, if you don't have a genetic diagnosis, many hormonal deficiencies can creep in. How often should we do it? I think 6 monthly for thyroid and perhaps yearly for other hormones, unless clinically indicated. That's how I would put it, Amannath.
Thank you, sir. One more question on behalf of PGs. So,
Sure.
how to titrate the dosage of growth hormone during therapy, especially in growth hormone deficiency?
Yes. See, for the information of the PGs, response to growth hormone therapy is an S-shaped curve. So what it means is, at very low level, it doesn't really work. Then when you put the dose up to something like even 10 or 15 microgram, it starts working. It works almost like a straight line up to 45 microgram per kilo, and then it becomes an absolutely flat line. So pushing the dose up beyond, say, 40 or 45 microgram per kilogram in GHD is of no value. It will become a straight line. The dose response curve becomes a straight line. So I start at a very low dose, as low as 15 microgram per kilogram per day. And many children respond beautifully to that dose. Monitoring by anthropometry first, and IGF-1 more for safety than for efficacy. So efficacy is based on anthropometry. Safety I will check based on IGF-1 higher values. Always try to keep them below +2 Z score.
Thank you, sir.
Thank you, sir, for your beautiful lecture and your good insights about growth monitoring in children.
Thank you,
So,
Javinder.
we will move ahead with the second case.
Yes.
So, thank you, sir. So the short stature is much more common, and the non-endocrinal causes are much more common than the endocrinal causes. So now we will have the presentation of a non-endocrinal cause for the short stature. And Dr. Ankita Soni is going to present her case on non-endocrinal short stature. And she has been guided by Professor Asima Dabas from MEMC. And Dr. Ankita is a PG student, third year. And the examiner for this case is Professor Anju Seth. Ma'am is director, professor, and the principal of Lady Hardinge Medical College. She has a vast experience in pediatric endocrinology, and she has great research profile, and ma'am is an excellent teacher. Over to Dr. Ankita. Please start sharing your screen and start presenting your case.
Thank you, sir. Is my screen visible?
Yes, Ankita, it's visible.
Good evening, everyone. So today I'm presenting a case of a 4-year female child resident of UP who presented to peds surgery emergency in view of acute abdomen. Child was managed conservatively for acute pancreatitis and transferred to peds medicine for further medical management. Child was having complaints of increased urine output for 2 years. In terms of child used to wake up 4 to 5 times every night and pass large volume urine. Along with there was complaints of decreased weight and height gain for the last 2 years. There is no history of fever or burning micturition or recurrent loose stools. There is no history of excessive tea or caffeine intake, no history of polyphagia, no history of any seizure or headache, trauma to head, or any altered sensorium. There was no history suggestive of any visual impairment or hearing impairment, any chronic drug intake, any weakness in the limbs, tuberculosis in the past, or any behavioral abnormality. In the past history, there is no history of previous hospitalization or chronic treatment in intake. Antenatal history was uneventful. Birth weight of the child was 3 kgs. Rest of the birth history was uneventful. Child is a product of third-degree consanguineous marriage. There is no history of tuberculosis or diabetes in the family. Child is developmentally appropriate for age and fully immunized till age. Dietary history, child had calorie deficit of 30% and protein deficit of 20%. On examination, child was irritable. However, vitals of the child was stable. Child was maintaining a blood pressure of 96 by 54 millimeter of mercury, which lies between 50th to 98th percentile. Height of the child lies at minus 4.59 standard deviation, and weight of the child was at minus 3.90 standard deviation. Weight for height for this child was minus 1.46, mid-parental height being 151 centimeter, and upper segment is to lower segment ratio was 1.28. Here we can see that this child was having significant growth faltering in the absence of obvious dietary scarcity. General physical examination. Child was thin built, conscious and cooperative. No facial dysmorphism. Pallor was present, however, no icterus, cyanosis or clubbing. Oral hygiene was maintained. Signs of some dehydration was present. Eyes were sunken but normal skin pinch. No lymphadenopathy or edema. No signs of rickets or any other micronutrient deficiency was there, and genitalia was normal. Rest of the systemic examination were within normal limits. So summarizing my case, 4-year female child, developmentally appropriate for age, fully immunized for age, with no history of any chronic illness, presented with acute abdomen along with polyuria and growth faltering for the last 2 years. Examination revealed mild pallor with signs of some dehydration. Rest of the systemic examination were within normal limits. After this history and examination, the differential diagnosis for my case would be I'd first like to keep the DD of diabetes mellitus. My second DD will be chronic kidney disease since the child was having polyuria along with growth faltering for the last 2 years. Third DD was renal tubular disorders, and fourth DD can be psychogenic polydipsia also.
Ankita, may I stop you here?
Yes, ma'am.
So I was wondering, your child has polyuria for 2 years, right?
Yes, ma'am.
Do you think you would like to keep diabetes mellitus as number one possibility here? In other words, would type 1 diabetes child, is he likely to present after 2 years?
Ma'am, it is very less likely. I think I should keep it lower down the possibility.
Yes,
But-
typically type 1 diabetes presenting with polyuria would just be weeks before the child goes into DKA, right?
Yes, ma'am. Yes,
Please go ahead, Ankita.
yes, ma'am. On investigating, complete blood count of the child was shows mild anemia. Hemoglobin was 9.9. KFT was within normal limits. However, child was having hyponatremia and hypokalemia. Child was having transaminitis. CRP was elevated, likely due to acute pancreatitis that the child was having. Same was reflected in the amylase lipase levels. Random blood sugar was 107 and HbA1c was 5.7, which was within normal limits. TB workup of this child was negative. However, venous blood gas showed metabolic alkalosis. Blood pressure was within 58 to 90th centile, and urine output was documented to be 7 ml per kg per hour, which confirms polyuria. On further evaluation, on further investigating this child, we found that serum chloride was at the lower levels. Child was calcium was 8.3, which was at the lower side. Vitamin D was vitamin D was less with elevated PTH. Rest of the tier 1 investigation for short stature, thyroid profile was within normal limits. TTG was less than 10 milli international units per ml. Bone age was 2.5 years. Chronological age for this child was 4 years. Stool microscopy and urine microscopy were within normal limits.
Just one more question here, Ankita, just because we've heard Dr. Vaman tell us how to look at the relationship between chronological and bone age, etc., to decide what kind of a disorder a child has. Can you also tell us, you told us the bone age was 2.5 years and height age was, the chronological age was 4 years. Can you also tell us the height age of the child? It would be a good
yes,
way of seeing a possible cause of short stature. It would be a lead.
Yes, ma'am. From the growth chart, if we see the height age of this child will be at around 1 year 8 months.
Okay, around 1.5 years, which means the bone age is more than the height age here,
Height age.
right? All
Yes,
right.
ma'am. Urinary parameters. The chloride of the child was 98 in the urinary electrolytes, chloride was 98 millimoles per liter. Urinary calcium creat ratio was increased, and urinary potassium creat ratio was also increased, that is more than 1.5. Urine osmolality was 581 milliosmoles per liter. So after this, differential diagnosis of hypokalemia along with metabolic alkalosis with significant growth faltering, I'll keep the differential diagnosis of Bartter syndrome, Gentleman syndrome, cystic fibrosis, diuretic abuse. However, there was no history of any chronic drug intake in this child, and Liddle syndrome. Afterward, ultrasound whole abdomen was done, which showed hyperechogenicity in bilateral renal medullary pyramids, suggestive of medullary nephrocalcinosis. Rest were within normal limits. So growth faltering in this child, growth faltering along with hypokalemia, along with metabolic alkalosis and hypercalciuria points us towards the etiology of renal tubulopathy. To confirm the diagnosis, whole exome sequencing was done, which showed KCNJ1 gene mutation that affects usually ROMK channels seen in Bartter's pathogenic for Bartter syndrome type 2. So child was managed with oral ORS replacement. Tablet endomethacin was started at 2 milligram per kg per day. Child was given potassium supplementation, high sodium diet, and kept in regular follow-up visit every 3 monthly for growth monitoring, electrolyte, and kidney function tests. Current status after 6 months, child was monitored, which showed significant weight and height improvement. The metabolic alkalosis part also improved, and hypokalemia was also improved in this child. Thank you, ma'am.
Ankita, thank you. Can you go back to the previous slide?
Yes, ma'am.
Okay. So what your case has very nicely demonstrated is how a systemic disease can lead to growth failure. So I would see, we can see the weight has increased, we can see the length has increased, but for us to very easily see that there is an improvement, if we look at the growth chart, it becomes a little difficult to see height, how much actually it just seems to be parallel to the centile lines. So it might have been better if you could tell us the previous Z-score and what is the current Z-score, because that would tell us any obvious increase in that in Z-score that would indicate actual improvement. So is that all right?
Yes, ma'am. Yes, ma'am. Yes, ma'am.
Okay. And just one question for you. What do you think are causes of growth faltering in a child with Bartter syndrome? Why do you think your child is so short?
Ma'am, in this child, since the child is having significant polyuria also, which lead the child to increased water intake. Due to this, it had been documented that child because child takes more of water, they take less of the food and calorie intake, so they might have growth faltering also, since it is chronic. It is a renal tubulopathy, a chronic disease, which is a state of increased metabolic demand for the body. So
Yes,
this might
these are both factors. In addition, chronic hypokalemia, hyponatremia, and dehydration. All of these would have their impact, because the caloric intake you very nicely shown, there is some deficit, but as you rightly pointed out, was not enough to explain the severe short stature. So it's a combination of all these factors, including dehydration and electrolyte imbalance. And also there are some case reports where some of the cases of Bartter syndromes have been shown to be having a growth hormone deficiency also. And these were, of course, suspected when the patient did not respond to the usual management and were found to have growth failure. Thank you, Ankita.
Thank you, ma'am.
Thank you, Dr. Ankita. Ma'am, we can have your lecture now.
Yeah, if anybody else wants to ask her any question, and or Dr. Ashima, would you like to make a comment? You are the moderator for this case.
Yes, ma'am. Thank you. I think Ankita presented very well, and the reason we thought to present this. Hello. The reason we wanted to present this case was because this child actually came to us as acute abdomen, and it was that significant growth faltering which made us investigate the cause of an underlying systemic disease. We did cut short that acute pancreatitis part for the sake of presentation, but very starkingly, I think what Dr. Vaman's lecture also beautifully covered was the need to monitor growth, look at growth in all the patients who present with any systemic complaints or any complaint in the growing areas. That was the most important message that we wanted to drive home with this case, ma'am.
Absolutely. So as far as pediatrician is concerned, and if we look at all the causes of short stature, chronic systemic diseases will rate very, very highly. And that is why we would always screen for them before we think of endocrine causes, unless obvious leads are present. Thanks.
Madam, with your permission, I have a few questions to Ankita.
Yes, please go ahead.
Yes, sir.
You are told about the medullary nephrocalcinosis. Is there any relation between medullary nephrocalcinosis in our ultrasound finding and with Bartter syndrome?
Sir, usually in Bartter syndrome, we have hypercalciuria, which can cause medullary nephrocalcinosis. In contrast, in case of Gentleman syndrome, we do not have hypercalciuria. So, medullary nephrocalcinosis points towards the hypercalciuria, which points towards the etiology being Bartter syndrome.
Very good. How will you monitor medullary nephrocalcinosis and hypercalciuria?
Sir,
How will you treat and
calcium
how will you?
create ratio.
Very good. Very good. Correct.
Thank you, sir. Thank you, sir.
Good. One more question. Sorry, madam.
No, please go ahead.
You have told first diagnosis as diabetes mellitus. So normally diabetes mellitus chronically it can present as a DKA, but if it is associated with some other condition, some other hormone deficiency, can be decompensated, not going for DKA, presenting as a late, just weight loss. I was with my professor, Dr. Raghupati sir. So he was seeing that case. Just based on growth chart, he told child has developed this condition. That is diabetes mellitus. Can you tell what is that condition? Clue is already given, hormone deficiency.
Yes.
Other PGs. Polyendocrinopathy, another one clue given.
So cortisol deficiency, where the requirement of insulin will be very low.
You are nearer. One more step. Most common, hypothyroidism.
Okay, sir.
Yes. Good.
Thank you, sir.
Thank you.
Just one more question again from my side, Ankita.
Yes.
Can we explain the combination of Bartter syndrome and pancreatitis? Does Bartter syndrome in any way predispose to pancreatitis, or was the child just double unlucky?
Ma'am, there was an adult case report that says in which there was association of Bartter syndrome type 2 with pancreatitis. So they have kept a possibility that since ROMK channels is present both in renal tubules and pancreas, there might be some association with KCNJ1 mutation that affects ROMK channels that might predispose these child to pancreatitis. However, no definite evidence of this, and we need more of case reports like this to.
Yes. So Bartter syndrome is genetically heterogeneous, and each gene mutation may have a profile distinct from the other. The growth hormone deficiency that I was talking to you about has been more reported with type 3 Bartter syndrome.
Yes, ma'am. Thank you, ma'am.
Just to add, we also went back and searched if with this mutation we could get something that could explain the association. Till so far, nothing has been reported, but yes, we are looking forward to, I think, as sir commented on the first case, the more we know now about genetics and the phenotype correlations, I think we'll be wiser in the next few years to understand this mechanism perhaps. Thank you. That's it.
So, should I go ahead now?
Yes, ma'am. Yes, ma'am. Please.
Okay, are my slides visible?
Yes, ma'am. Your slides are visible. Please make them in slideshow mode.
Yes, I will. So, we've heard a case of systemic disease leading to short stature. So, I'll briefly lead to an approach to how do we approach a child when we see one with presenting with short stature, and this actually constitutes a fairly large proportion of cases coming to pediatric OPD. If they have tall stature, they won't come, but short stature, real or perceived, they will always come. So just a minute, I'll go to slideshow. So this was a summary of the case, which was obviously a case of a systemic disease leading to short stature. This girl was symptomatic for 2 years. She did have some deficit in calorie and protein, which added to it, had a normal birth weight, And the anthropometry showed a severe height deficit, and the height age, as we found out, was just about 1.5 years at a chronological age of 4 years. Weight was also almost affected in a similar manner, minus 3.9 Z-score, and weight for height Z-score was within the normal limits. Did not have any obvious dysmorphism here. Did have dehydration, but systemic examination was normal. And the investigations clinched the diagnosis. Here, the bone age was almost the same as height age. Profound hypokalemia, hyponatremia, metabolic alkalosis. The diagnosis was pretty clear. So, among all the short children whom we see, who requires evaluation? This has been covered by Dr. Vaman, but very, very quickly. If the child's height and weight compared to the reference standard, and we've seen the IIP reference standards, that's what we use. For children up to 5 years, we use WHO. Beyond 5 years, we are using IIP reference standards. If these parameters are less than -2 Z-score, and the child's height compared to the genetic potential. Again, Dr. Vaman has very nicely explained how to compare a child's height to genetic potential. I'm not going to repeat that. If it's below the target range. Thirdly, if we have a review of serial records and there is a down crossing of centiles. So in this particular case, we learned there was no serial record. We just had a single value. Your case becomes so much more stronger if you have a record of a serial record of height and weight, because this would help you comment on height velocity also. So any of these three is when you would evaluate a child for short stature. So this particular child, if you see height for age minus 4.59 Z-score, definitely meets the criteria. And this was the growth chart of the child. See, way below the third centile, it is way below the MPH target range. Again, so the child meets this criteria also, and we don't have a review of serial records. So just showing different kind of growth charts. If we have serial values, these are actually quite diagnostic. If you look at this child A, the solid blue dots, this child is, and we also have the height plotted here, is below the third centile, below the mid-parental height, but growing at a normal height velocity. So, however, even though he's going at a normal height velocity, he is below the third centile and he is below the MPH range. Therefore, this child A requires to be evaluated. If you look at child B, he is also below the third centile, but differs from child A because his height velocity is also low. How do we know height velocity is low? Because with each recording, he is going away and away from the growth centiles, the height centiles. So it is actually almost flattening. So this child again requires evaluation. If we look at child C, this child's, the latest value of height is above the third centile and he is also within the MPH range. So if we were to look only at the last value, he does not qualify as having short stature. But we have his previous values which show the down crossing of centiles. So this kind of a graph is available to you only if you have serial records. Therefore, this child, though his height is above the third centile and within the MPH range on the last testing, still qualifies for testing for short stature. And so does this child D, who is pretty much similar to child C, except that he is in the adolescent age group. And in this age group, we would interpret this child's height in relation to the child's pubertal development. If this child has delayed puberty, then there is a lot of remaining height potential and he may catch up. If on the other hand, he has completed his puberty, then this short stature is likely to get further exaggerated. Before we look at the approach to short stature, just a one word which might seem obvious, but we all still make errors on this because sometimes we don't measure ourselves. We might ask the junior most member of our team to measure who may be unfamiliar. So do make sure that the measurements, the recorded age, both are correct and you use the correct growth reference. So why do we want to evaluate? We want to evaluate because we want to classify the children broadly as those who are normal and short because they do not reach.
I think Madam has power cut.
Madam
just
has
had a
lost
very
connection problem.
Yeah, we've just had a very bad sandstorm in Delhi. Even I lost my network for some time. I think we can just wait for 2 minutes. Ma'am will take 2 minutes to join back.
Yes, we can wait for.
With Javinder's permission, few points I wanted to tell about the first case for PGs till Madam comes.
Yes, yes,
give-
please go ahead.
Yeah,
Please go ahead. The
give
show must
importance
go
to
on.
the history. So nowadays, postgraduates, we are not giving importance to the history. So try to take proper history in growth, especially where the child is sitting in the first standard, second standard, third standard in the first bench, second bench, third bench. Again in the prayer line, and if possible, try to collect the growth record from the
Hi,
parents
I'm
or the
back.
school. Yeah, please, over to you,
I'm
madam.
sorry,
Ma'am is
there was
back.
this huge storm outside and the light just went off. Are my slides still visible or do I need to connect again?
Connect again, madam.
Connect
Okay,
again.
okay. Just give me a second. Okay, so share and visible?
Yes, ma'am. there.
Yes, ma'am, it's visual.
All right,
Please put on screen.
fine.
Yes.
Yeah. So I was saying that we need to identify and classify the children in three, but rather and three causes cannot be treated. And third and most important, they have a remediable cause of short stature so that we can catch them and they can benefit from treatment. So this case has demonstrated nicely what history we need to take. Birth date, weight, length are important. We want to see if the child was born SGA because so many syndromic short stature children are born SGA. We would like to know from the history, is the child only short or is the child thin and short? We'd like to see how much diet is contributing to it because nutrition is a very important factor driving the stature, especially during the early years. Look at the development, a quick systemic review, past treatments, family history of short stature, delayed puberty, endocrine illness, all these are important. So if we see from this child, the child had a pretty good birth weight of 3 kg. The child was past history showed the child was symptomatic for 2 years and there was definitely a dietary deficit also in calories, proteins and otherwise in probably variation as well. Examination again, we would like to look for and the evidence of systemic disease as well as specific endocrine disorders and syndromic short stature. So we would like to look for phases, midline defects, micropenis for growth hormone deficiency, thyroid enlargement for any goiter and goitrous hypothyroidism. Remember, a lot of hypothyroidism in children is non-goitrous. That's more, especially in a young child, likely to be because of thyroid dysgenesis. Any neurocutaneous markers, disproportionate habitus, rickets, truncal obesity, specific syndrome. And also, one would like to look for subtle signs of skeletal dysplasias, like mid-lung deformity of the forearm, limited rotation of forearm, short and broad forearm, tibia bony, scoliosis, micrognathia. So these are all subtle signs of skeletal dysplasias. The gross skeletal dysplasias are obvious as a disproportionate habitus. Then a quick systemic examination and pubertal assessment in an older child. Anthropometry is really important. So height or supine length, depending upon the age of the child, weight, the upper segment, lower segment ratio, arm span height difference, mid-parental height, So with all this, take some time to develop a growth chart. Try and look for the previous values, because the previous values will give you height velocity as I just demonstrated. And that will really help you also kind of pinpoint the onset of disease. And so make an effort to get previous records. So our child, it was, we did not have previous records, but the current height deficit was fairly severe, as was the height deficit in the child that was presented by Dr. Sahana earlier. And weight for height is not too badly affected. It is well within the normal range. This was the growth chart of the child we had already seen. So height, even a little bit more affected than the weight, but height well below the mid-parental height centile. So what is the etiology of short stature we are looking at? Very broadly, your child you are evaluating could be just grossly, is he looking normal or is the child looking unusual? So if the child is, let me have a pointer here. If the child is looking normal and the child also has a normal height velocity, then it is very likely he has a normal variant short stature, which could be familial or which could also be a constitutional delay in growth and puberty. However, if the child is looking normal, but height velocity as either measured prospectively or you have the previous records and you've been able to construct a growth chart, if height velocity is low, then look at the relative involvement of weight and height. If the child's height is faltering along with weight faltering, typically such a child would have a low weight for height or a low BMI also. Then you are likely dealing with a chronic disease like malnutrition, anemia, any systemic disease, such celiac disease, CKD, etc., renal tubular defects. So typically in a chronic disease, weight centile could also be faltering. In this particular child, weight for height was minus 1.6. So well within minus 2, it was not really below minus 2. But most of the chronic systemic diseases, the weight would be low. If on the other hand, weight is not that much affected. Remember, any short child, if there is profound short stature, weight for age would be low. So weight for height or BMI is what you're going to look at and not really weight for age. So typically in an endocrine short stature, weight for height or BMI centiles are well maintained. The child may not be obese. In fact, child is usually not obese, but weight for height is well maintained. So that's one way of very grossly if a child is looking normal. If on the other hand, the child he looks unusual, then let us see why is he looking unusual? Is he unusual in body proportions or is he unusual in head, limbs or skin? If it's unusual in body proportions, you could be dealing with rickets, you could be dealing with skeletal dysplasia or mucopolysaccharidosis. If on the other hand, the unusual look is in terms of head, limbs, skin, then there might be recognizable syndromes. There's a variety of syndrome, or he could be a SGA baby, like Russell Silver 3M syndrome, or others. So this is just a gross way of looking just on your clinical assessment in which category your child is likely to fall. So after that, you would do basic investigations will be done for all cases. And this is a quick systemic screen and was done for both the cases that have been described here, as well as a bone age assessment. So in our particular case, we had very stark finding. There was hypokalemia, hyponatremia, there was metabolic alkalosis, and chloride was low, high urinary calcium creatinine ratio, nephrocalcinosis, urinary osmolarity increase. So very obvious pointer towards a systemic disease. And bone age here was nearly same as height age. But in a otherwise, the other test that you might like to do in a child who looks quite well, sometimes the short stature may not be so overt. So CKD is one other disorder which you would like to look at. Venous blood test must always be done in a child with short stature. Again, you might miss. Here it is Barters. RTA is another disorder which can again present with short stature. Stool for giardiasis and thyroid function test is always counted as a first line. So here is again what Dr. Vaman had told you. bone age is a very important tool in evaluating a short child. And in general, if the child has a familial short stature, he's short because the family is short, his bone age would not be delayed. It will be same as the chronological age, though height would be low. If you're dealing with a chronic systemic disease, the child is short. Therefore, chronological age is more than height age. In chronic diseases, as in CDGP, typically the bone age is also delayed, but usually would be around the height age. It is not delayed beyond the height age. Vis-a-vis in most endocrine disorders, especially if you're dealing with multiple pituitary hormone deficiency or you're dealing with growth hormone deficiency or hypothyroidism, bone age may be more delayed than even the height age. In this particular case, the bone age was not more delayed than the height age, neither was it in the previous case, but in most typical cases, it would be. Okay, so these things would give you an idea as to what kind of a disorder you're dealing with. So these are our second line investigations that you would do. In North India, celiac disease is so common, we count it as a first line investigation. But do remember to do karyotype for all girls with unexplained short stature. And finally, provocative GH testing and testing for RTM. So I will not go through this algorithm again, but this is a summary of what has been demonstrated by the case and what I have said, that any short child, you would look at the anthropometry, the family history, the present and the past history, and the child's examination, current examination. And on the basis of these, we are going to evaluate the child. And on that basis, we are able to differentiate a child as familial short stature or constitutional delay in growth and puberty, which are the normal variant short stature. We might be able to diagnose them as SJ babies with poor catch-up, or we might be able to pick up children with disproportion, dysmorphic features, which disproportion leading to skeletal dysplasia, dysmorphic features specific suggestive of specific syndromes, endocrine disorders, or underlying chronic systemic disease. So the key messages that I would like to give here is that you would evaluate the growth of a child with reference to age and sex appropriate reference standards. You need to be accurate in your measurements and recording age, as well as considering the parent's height in evaluating a short child. Getting the previous records would be very valuable and would help you look for growth velocity. Most of the cases, at least in a common pediatric OPD, are likely to turn out to be normal variant short stature or because of chronic systemic diseases. Some important occult chronic systemic diseases presenting as growth failure are RTA, renal failure, and celiac disease. And important endocrine conditions, of course, we had a case which had multiple pituitary hormone deficiency, and others that include isolated hypothyroidism, GH deficiency, rickets, and Cushing syndrome. And bone age is an important investigation indicating underlying cause as well as the remaining height potential. So thank you very much.
Thank you, ma'am. And
Thank you very much, ma'am.
It was very informative lecture. So we can have one, two quick questions if we have. So PGs, if you have any questions, you can ask me.
Madam, on behalf of PGs, I shall ask. So apart from treating the systemic cause, is there any other role of like using growth hormone in systemic conditions?
Yes, variable, for example, CKD. Yes, it's the cause of short stature in systemic diseases is very variable. So one would use them in certain situations and the results are variable. CKD, one can use them, of course, apart from the systemic management. Idiopathic short stature one would use in cases where there is syndromic short stature, say Russell Silver. It's shown to have variable effect. So one would, depending on the disorder and the evidence, one can use growth hormone therapy in some of them.
Thank you.
I have one question.
Yes, Dr.
Yes.
So, ma'am, we use sometimes the term of nutritional growth retardation. So if we can clarify it for everybody as to what would it be, when would we be labeling a child with nutritional growth retardation, especially in the context of a systemic disease?
I couldn't, sorry, Ashima, could you repeat the question? I couldn't catch it
So
here.
the Western textbooks talk of the concept of nutritional growth retardation, where the cause primarily, I think they talk of something like an failure to grow because of extreme undernutrition and malnutrition. Do we are we justified in using that term, or when do we use it really in the context of our patients?
So I would say, Ashima, if we are looking at the first couple of years of life, where the growth is primarily nutrition driven. So at that time, if a child has undernutrition, that is not only going to impact upon the child's growth during those 2 years, but it is going to lead to a permanent height deficit. Therefore, a lot of stunting that we see at a community level could be because of nutrition. Okay? And so these children over time might actually recover in weight for height, so they might just end up having stunting itself. So nutrition definitely is an important role, not only alone but even as a component of various systemic diseases also. It would come, for example, the case that you showed, again nutrition was one of the factors, because appetite gets affected in all chronic systemic diseases. But having said that, nutritional short stature would primarily refer to a chronic undernutrition. And this chronic undernutrition perhaps could also be in utero. If we expand that concept, in utero malnutrition may also contribute to it. Okay.
Thank you.
So thank you, ma'am. Thank you very much for your.
Just 1 second, Javinder. So on behalf of ISPAE, we are proud that Madam is principal and director. Congratulations, Madam, and we would like to have your blessings for our ISPAE. Thank you. Wishing you all the
Always,
best.
I'm a
Yes.
member of ISPAE, have
Yes,
been a secretary,
congratulations.
Madam was
president.
president also previously.
And it's very much I have a lot of ownership, a sense of belonging with this organization. And thank you very much, all of you, Dr. Amarna, Javinder, Vijay, for inviting me and being part of this program. Thank you.
Thank you so much, ma'am. Thank you.
Thank you, ma'am. So now we will move ahead with the next part. So it's time to rebrush our knowledge. So it's PG's turn to answer the questions you have heard about these growth disorders, both by Dr. Vaman Khadilkar and Anju ma'am. So now Dr. Nikhil will be presenting the OSKI. So PGs, we encourage you to participate and answer as much as possible. So over to Dr. Nikhil. You can start presenting you. And we have around 20 minutes for OSKI.
Okay, thank you, Javinder sir. Am I audible?
Yes, you are audible. Please start.
And I'm just sharing my screen. Is my screen visible?
Yes, your screen is visible.
Yeah. So without further ado, thank you very much for the organizers and ISPAE for giving the opportunity to have discuss common what we get in our exam.
Dr. Nikhil, you are not audible. You are not audible to me, or?
Even I was wondering.
Yeah, some
We
internet
also had a
issues.
power cut. Maybe. I think we'll wait.
So I shall ask one small question on behalf of him, Nikhil. So for the PGs. So case of growth hormone deficiency, do you want to use daily growth hormone injections or the, yes, he is back.
I think I'm sorry, there was some
Weekly.
connection glitch.
Go ahead.
I'm audible to you people.
Yes,
Yes,
yes.
Yes.
Yeah. Sorry for the mishap. I'll just share my screen. Yeah, so is my screen visible?
Yes, go ahead.
Yeah. So PGs, can you answer the first question, which is identify the charts given below? Anybody would like to volunteer?
It's IAP growth chart, sir.
Very good. It's IAP 2015 reference chart. So what are the oxylogical parameters it is used for? The given chart basically.
Weight and height, weight for each and height for each.
Very good. Very good. Is it a standard or a reference chart?
It's a reference chart, sir.
Okay. What is the difference between a standard and a reference chart?
Standard chart is a descriptive chart which shows us how the child is actually supposed to grow. And reference chart is the one which shows how the child is actually growing as compared to the
Prescriptive.
population.
Yeah. Very good. So what are the cutoffs used to identify the abnormalities or pathologies using these charts? Cutoffs for the oxylogical parameters.
So height being less than third centile is used as a definition, and if the upon doing growth monitoring over the course of time, if the child's height is falling, it's crossing two major centiles,
Very good.
which shows short stature in a child. And
Very
we can
good.
also plot mid-parental height and assess whether a child is within the genetic potential or way below from the mid-parental height.
Very nice. Actually, very impressed with the answers. PGs are very thorough. Perhaps the lectures has helped a lot. So yes, it's IAP 2015 reference charts. And please mention the gender. It becomes more impressive that you know blue and pink. OSKI is a lot about flaunting your knowledge. Whatever you have, you can pour it down. It's better to write little more, but not to be over smart though. But you can write more. Height or stature and weight and BMI if it is available. Usually they'll keep all of them. These are reference growth charts. I think the description we will discuss in the next slide. Height more than 90th centile and less than 3rd centile are the cutoffs considered abnormal. Above or below one standard deviation from MPH is considered as abnormal. Weight above 97th or 3rd centile is considered as abnormal. Now talking about reference and the standard charts, we all know reference charts shows how the children are going. So perhaps even if you write 2 of these points, I think the examiner should be happy with you. These are based on cross-sectional, these are prospective, longitudinal, easy to acquire, difficult to acquire, potential to overdiagnose, underdiagnose, prescriptive, descriptive, how the children are supposed to grow, and all these points will help. And these perhaps may be a few additional questions which may be asked to you. What are the 7 percentile lines? So you're supposed to answer them. What are the BMI additional? BMI charts have additional cutoff for overweight and obesity. It's the 85th and 95th as per the WHO charts. Indian charts, the cutoffs are different. We expect perhaps a little it is high. I mean, good to know kind of a question, but if you know it, it's good. 50th centile is the average line. Any child above below 97 and third is considered abnormal, and the movement of two major centile is considered as something is wrong with the child. So very well. Now let's move to the second OSKI. OSKI number 2. A 12-year-old child was brought with the complaints of fever for 3 days. The girl was noticed to have ear discharged and enlarged tonsils. Parents also complained of not gaining height. Please proceed for the anthropometric assessment and interpretation. I don't expect answer from this, but this is just a video to depict. You might be having this practical OSKI where you are supposed to first initially introduce yourself. Who are you? And ask, is it fine if I talk to you? Name and date of birth. You ask the permission whether you can take the height or not. Explain them the procedure by which you will be doing this. Very important observation. Purposely, there will be socks or shoes. the patient will be wearing. So you are supposed to remove them. Hair clip, hair band, and hair belt. All those things might be expected from you to be removed. Knees to be straight, child to look straight, slight chin tilt, and you are expected to bring that headboard downwards. And then closest observation has to be mentioned, and you have to tell, you have to tell that I will take 3 subsequent readings, if at all, and I'll take the average of them. So again, another clues will be like if you have parents, you take parents' height also, weight also, and then you plot on them. And BMI also might be expected if charts are available. Better to do more things rather than missing any of them. Interpretation here, if you look carefully, the girl is normal for the population, but we do not have MPH. If parents are there, you'll have to plot on the MPH and tell based on mid-parental height and population expectation, the child is landing XYZ position. So this is just infantometer, how 2 people will be needed to measure the length of a child. This cartoon has been taken from Piyush Gupta textbook of pediatrics. Not textbook actually, it's the clinical book where you can see very beautifully description given. Remember, 2 people might be needed to assess the height. One person, both are on their knees, especially for a younger kid. And what is Frankfurt plane? You might be expected to answer that. And here is the pictorial description of the same. Another OSKI here, I'll need some active participation from the postgraduates. A 3-year-old child has been referred from Anganwadi for growth assessment. The height and weight and head circumference are given here. You will be expected to plot this chart on the plot these oxological parameters on the growth chart and give your interpretation. What other anthropometric parameters would you like to assess? Will you send any investigation for this child? If yes, mention them. So any PGs, can you tell me which growth chart you will be using for this 3-year-old child?
WHO growth chart, sir.
And which color?
You not mentioned boy or girl.
Very
Gender
good.
is-
So basically you are expected to ask the examiner, sir, whether the child is boy or girl. So that shows your attentiveness and how alert you are at the time. So this is very important. And once you get the charts, the examiner will say is a boy or a girl, and then you're supposed to plot them. Now, if you have a boy, it's a blue chart, girl, you have pink chart. These are the charts which are commonly used, you already have seen. Weight for length chart for boys and girls are also available. They might also be given to you. And mid-arm circumference chart might be kept there just to confuse you, or we will see subsequently what it needs to be done. So these are the steps which actually we use. We make sure that which chart are being used, the gender, blue or pink. Then we note the anthropometric parameters. You measure the parental height and calculate the parental expectations, plot them carefully and calculate the height, age, weight, age, and then interpretation is based on the population and the parental expectations. So here are the plotted growth chart. And one point very clear I want to mention, there should be a dot or a bold dot rather than being a circle and inside there is a dot, which is a very common mistake majority of us do. So any of the PGs, can you interpret this growth chart? Any PGs, please?
Well, how is the height, weight, and head circumference? All
Okay.
three.
Where is the height? Where is the height lying on this growth chart? Is it normal? Is it short? Is it below any centile or anything like that?
Yes, Sahana, Ankita.
Sir, height is less than third centile. That comes into short stature. Head circumference is between 3rd and 50th centile, and weight for age is less than 3rd centile, sir.
Okay.
So
And weight
child
for
is
length?
underweight. Child is underweight with short stature, and weight for length in this child lies at 3rd centile.
Just above third centile. So see,
Just
this if you say below third centile, that is also correct. But specifically in that chart, you say first centile is also there. So the most appropriate answer is height is below first centile. So definitely short child circumference with a low weight for age, but weight for height is normal. So essentially it is height which is more affected than the weight aspect. So would you like to assess anything in this child? Any other anthropometric parameter?
I would like to look at mid-upper arm
Yes,
mid-upper arm
very good.
circumference also.
So many times there are charts available, everything which will be available on your station, perhaps they have to be used. So they have put it for a reason. So the next question was what other anthropometric parameter or anything else you would like to see. So obviously you'll plot a mid upper arm circumference. Then the examiner will say the mid upper arm circumference is 12 centimeters. Then your interpretation will be this is low for the age and gender specific. So this child is perhaps having nutritional component, because of which any workup would you like to do? It will depend on the response of the examiner. If it is underweight, you would like to see what are the etiology. You would like to know more of a nutritional status, calorie diet, proper diet intake, whether the child is taking properly or not. And then go ahead for any basic investigations, if at all. And dig in more history before jumping onto investigations. Then another OSKI, another 6-month-old child, referred from Anganwadi. These are the oxological parameters, which are height, weight, and the head circumferences are given here. Now, if you look, another history which is very carefully given is baby was born 32-week preterm with a birth weight of 1.7 kg. Plot the anthropometric parameters on the growth chart and give your interpretation. What other anthropometric parameters would you like to assess, if at all? Will you subject the child for any investigations? Or if yes, mention them. Now, very clearly, this job has been made a little easy because I plotted the growth chart, but you are expected to do it. And any of the PG, can you read this growth chart? Where will you plot this child at 6 months or anywhere else in the growth chart?
We need to plot at the corrected gestational age.
Very good. How much correction will you subject the child to, or his age to rather? He's 6 months old. She is 6 months old. I mean, you need to know the gender also. I purposefully not put the gender. Let's say she's a girl. So how much correction you will do based on this gestational age of birth?
In this case, 2 months correction will
8
do.
weeks.
More precise, 8 weeks. 2
8
months
weeks.
is also correct. So you'll plot it around 4 months, some days. So that's what we have done. 4 months, 1 week somewhere we have plotted. And now can you interpret this growth chart?
So a baby's length is less than first centile, head
Very good.
circumference being less than first centile, and even the weight is being less, almost at first centile. And weight for length, weight for length is at third centile.
Yeah, it's falling into the category of moderate malnutrition as per definition. This child, would you like to do any investigation, or would you like to do any other workup or any other investigation or any other anthropometric parameter would you like to assess first of all? Again, the question will be mid-upper arm circumference. The first question will be, is there any history of any other issues or anything like that? And you can subject the child for subsequent monitoring. This is most likely an SGS sequelae, which takes a bit of time for growth. Only unusual thing is the head circumference is low. So perhaps you may be given a few at birth anthropometric parameters where you may use, depending on the charts which are given to you, Fenton or intergrowth charts. So if they are there, you are supposed to plot the sequential height monitoring, weight and head circumference monitoring. These are just depicting what are the intergrowth charts are. So this is, I think, very obvious for you all to plot how to plot the growth chart. Some of the questions will be interpretation. Some of the questions will be any other anthropometric parameters you will be expected, and what investigation, if at all, you want to subject the child to. Now, moving on to another OSKI number 5. A 7-year-old boy was on follow-up for a well child clinic, and basically he was coming for growth concern. Previous height monitoring was done 6 months back. The child has a height of 107 centimeters and weight of 19 kg. Current height and weight are 109 centimeters and 20.5 kgs respectively. Calculate the growth velocity, plot them on the growth chart, interpret it, and what will be your next step. So any bright PG, would you like to answer? What is the growth velocity for this child?
It's 4 centimeter per year, sir.
Very good. So basically you had 6 months back 107 centimeters. 7 years it is 6 months later it has gone 109. So growth velocity becomes 4 centimeter per year. Now the thing will be, you will be expected to plot it on the height velocity charts. These are the height velocity charts which are given to you. Where will you plot it? The plotting has to be done between
the 2 time periods.
Yes. So
Okay.
the midpoint of 6.5 to 7 is
6.75.
very good. So you have plotted it there. Can you interpret what it is?
The height velocity being less than 25th centile for the age and sex of the child. So the child is having short stages.
Very good. So growth velocity is down. That means there is faltering of growth. So definitely this is short stature which needs some further evaluation or anything like that. What will be the next best investigation for you to do? The answer is bone age. First thing, obviously you will be, you can ask about weight and other things, but if someone asks you a specific investigation when height is concerned, you will say it's a bone age. Which bone X-ray will you ask for?
Left hand along with the wrist X-ray will be asking, sir.
Till fingertips.
Fingertips, yes.
Yes, great. So I think we are very clear. The first investigation in any child who is short is bone age, given that the weight is not that much affected. Another OSKI, 6-year-old girl complain of breast development since 2 months. There is waxing and waning. The child was born SG. Height, weight, mother's height and father's height are given. Plot them on the chart. Calculate the height age, weight age, and plot the bone age, which is given 8.5 years, and make an interpretation. Now, this is slightly a different OSKI. Here, you are expected to plot and calculate height age, weight age, and bone age, which is given. You are supposed to plot it. What will be the next clinical assessment? So I think we have plotted the height and weight for you. The parental expectations, perhaps it is here. It's in white color, so it's not visible due to some technical glitch. So the child's height is within this range. It should be 25th to 10th centile. So here is his height. The parental expectation are between 10th and 50th centile. This is the bone age which is plotted. Now, just to make it easy, the height age is here, weight age is here, and bone age is here. Can any of the PG interpret the relation between height age, weight age, chronological age, and bone age?
Bone age is more than height age and weight age, which collectively is more than the chronological age.
Very good. Very nicely summed up. So this is what I was speaking about when you plot a chart. Make sure the gender is correct. Age, length, weight, and BMI has to be plotted. Head circumference, here it's not applicable. Mid parental height you have calculated. It is 156 plus minus 6 centimeters. You are supposed to plot them carefully. So weightage, I think there is some correction. Chronological age, weightage, height age, and bone age. So this is perhaps a child with
Precocious puberty.
Precocious puberty. The child is tall for the parental expectations, but normal for the population expectation. Next best thing to do is SMR assessment. You would like to do the sexual maturity rating assessment or Panner staging assessment. So this is what I think already has been discussed, but let's match the pairs. So first, chronological age, height age, and weight age will be equal in which of the following?
A normal child.
So 1 is equal to B, correct? Chronological age is higher than height age is higher than weight age, which will be the pair. How will you match this?
Nutritional or a systemic cause.
Very good. Chronological age, weight age, and height age, how will you match this?
Endocrine cause of short stature.
Very good. Height age, weight age, and chronological age, how will you match it?
Endocrine obesity. Nutritional obesity.
Yeah, sure. height age, weight age, and chronological age.
Precocious
Oh, sorry,
puberty.
precocious puberty.
Very
Sorry.
good. Weight age, chronological age, and height age.
Endocrine obesity.
Very good. And the last, obviously, weight age is higher than height age, is higher than chronological age.
Nutritional.
Nutritional obesity. So this is very important. This is expected. You may get this kind of OSKI, which are very straightforward. So this is just to depict the answer which we have just now discussed. I think perhaps last two OSKIs, OSKI 8, describe the phenotypic feature of this child. What is the differential diagnosis if it comes in your mind? How will you confirm the diagnosis? What is the treatment, drug, and dosage if at all? And what are the other indication of the drug? So let's move. Describe the phenotypic feature. Any two. Can anybody tell it?
Child has frontal bossing with midfacial hypoplasia.
Great. Very good observation. Then
Probably a single central incisor.
Micropenis.
Penis.
micropenis,
Yes,
very good.
micropenis.
And
Some child, yes.
there is peripubic fat along with that. Yes, there is a cherubic facies. Since the child is crying, you are not able to make out. The child had also had open AF at the age of 2 years and 4 months. So that's a little late. The fat distribution also seems not very okay.
Normal. Yes.
Yeah, and the child was definitely short. Yes, what is the differential diagnosis?
Could be a case of growth hormone deficiency
Very good.
or
Then,
growth hormone insensitivity.
very good. And multiple pituitary hormone deficiency also. Clarence is also possible. How will you confirm the diagnosis?
We'll do hormone.
So we'll have to do growth hormone stimulation test for the
The
child.
specific answer is growth hormone stimulation test. Very good. What is the treatment drug and dosage for this child?
A recombinant human growth hormone at a dose of 20 to 45 microgram per kg per day. It's given as a single dose subcutaneously at the night.
Time. Good, you have mentioned the range. That makes more sense. It depends on the indication. If you write it as in this patient with growth hormone deficiency, 20 to 35 microgram per kg per day, something like that, 40 microgram. What are the other indications of this drug?
So it can be given in chronic renal failure condition, syndromic
good.
shortages as Turner syndrome, Noonan syndrome, idiopathic short stature, shocks insufficiency,
Very
and
good.
Russell Silver and multiple pituitary hormone deficiency, as well as Prader-Willis.
Very good. Very thorough. Very good answer. Now, last OSKI, I guess. What is the test shown in the picture? What is the diagnosis? Enumerate any 4 clinical features of this condition and name the hormonal treatment, in bracket it is S, licensed for this condition. So what is the test shown in the picture?
So this is a karyotype analysis,
Yeah.
which is showing single X chromosome. It's a case of Turner syndrome.
Very good. So many a times this, what is the investigation, blood investigation shown in the picture? So you are supposed to write peripheral blood or blood karyotype.
Okay.
I mean, I'm just making it sometimes, making a little bit spicy tadka, something they'll put it like this so that you are more specific in your answer. Enumerate any 4 clinical features of this condition.
Usually kids will be short statured with web neck, widely placed nipple, low hairline with multiple nevi, presence of edema at the time of birth.
Yes. Short stature, mid-length deformity, short fourth, metacarpal, bicuspid aortic valve coarctation, and horseshoe-shaped kidney, blah, blah, blah. There are a lot of them, but if clinical is given, then I think these few characteristics which you have clearly mentioned are very appropriate. What are the hormonal or treatments licensed for this condition?
So for the growth, a recombinant human growth hormone can be given, and even for the puberty, child should be started on initially with estrogen followed by progesterone.
And what other, any other? I mean, I think they'll write it in bracket or any two or anything like that, but still, oxandrolone also can be used in this children.
Yes.
Also, you can write progesterone if at all.
Yes.
Actually, it's not HRT. I've written in bracket hormonal replacement therapy, but it's pubertal induction therapy. Hormonal replacement therapy, or rather replacement only, but not exactly HRT. It's the term which is used mostly in the adult gynecological treatment. So I think we are through with the OSKIs. PGs have done really good, and I thank everybody for your very
Okay,
active participation, and thank you, ISPAE, for the opportunity.
Thank you, Dr. Nipul. It was very nicely presented, and thank you, PGs, for participation. So now we are at the end of session. So I am just displaying what are the questions which are commonly asked. So are my slides visible?
Yes, visible.
So these are the common questions which have been asked related to growth disorders. So what are the causes of dwarfism? How will you investigate such a case? Define growth velocity, draw a typical height velocity curve from birth to puberty for boys and girls. And discuss
Yes, Dr.
the utility of
it is visible.
determining. Thank you, Dr. Vijay. So discuss the phases in growth disorders. Outline the clinical approach to a 9-year-old child with short stature and list the causes and evaluation strategies. Discuss the basis of use of growth standards and what should be taken as a reasonable approach for India. And write a note on growth monitoring in children. List age-dependent and age-independent methods to assess growth in children. Describe the etiology, clinical features, management of constitutional growth delay. Enumerate the causes of proportionate short stature in children and outline the diagnostic approach. Discuss the management of a child with idiopathic short stature and what are the controversies and surrounding the growth hormone therapy in this condition. Discuss the genetic and environmental factors influencing growth in children, and discuss the role of bone age assessment in evaluating growth disorders in children. Some questions related to growth hormone therapy, like discuss the hormonal and non-hormonal causes of growth failure, indications for growth hormone therapy, and role of growth hormone in pediatric practice. Enumerate various functions of growth hormone and describe indications for growth hormone therapy. And this one question was also on tall stature. Describe the evaluation and management of tall statures. So that's all from my side. Raghupat sir, for the last comments and sir's wisdom words. And
I'm very glad to see that the program was a great success with all the essential points required for postgraduates to face their exam. My main idea was to help the postgraduates to appear for the exam, and these were all pointed that way, and I'm very happy. And I'm also hoping more people will join in future so the postgraduates who attend can spread this information, and this will be available once in 3 months. And it's a golden opportunity for learning pediatric endocrinology, at least to face the exam, but also for their future practice. Thank you very much.
thank you, sir. Thank you very much for your kind words. So now we are at the end of our session. So I would like to thank you all the participants, Dr. Ankita, Dr. Sahana, Dr. Asima, Dr. Amarnath, Vaman sir, Anju Seth ma'am, Dr. Vijay Jaiswal, Raghupati sir, and the RX event team which has nicely managed this session. So thank you everyone, and have a nice good night. So good night, and we will meet
Thank
after
you.
3 months with another session.
Thank you. Thank you,
Thank
Dr.
you.
Amarnath, for active participation.
Congratulations to the team. Doing very well. Excellent.
Thank you, Dr.
No,
Thank
you are
you.
not out of the team. Amarnath, you are not
Yeah.
out of the team. You are always going to be there.
Yes.
Yeah,
Yes.
thank you, everyone.
Very good. Very good. Well done.
Thank you.
Thank you, sir.
Good night.
Thank you so much, sir.
Thank you. Thank